So next we'll talk herpes simplex viruses. Herpes simplex virus can be one or two. So it can be HSV1 or HSV2. And HSV1 causes orofacial herpes, and HSV2 causes genital herpes. And how does they look like? They look like a grouped vesicles on erythematous base, and if it's occurring over the lip, it's called herpes labialis. Okay, and here also you can see multiple grouped vesicles on erythematous base. When they rupture to form eruption, they have polycyclic margins. Okay, they have polycyclic margins. So how do they get transmitted? They get transmitted by contact. Contact can be direct contact and indirect. If the patient comes in direct contact with the contents of the vesicle, that is the vesicular fluid, then they can come in contact with the contaminated objects which has come in contact with that fluid, then it can get transmitted. It can get transmitted to sexual transmission, that is also by contact, then by vertical transmission from mother to fetus. So these are the modes of transmission. So they cause primary infection. After primary infection, they undergo latency, and after that, they can get reactivation. So this latency for herpes simplex virus and varicella zoster virus, it's in the sensory ganglia. Okay. For HSV1, it is in the trigeminal ganglion. For HSV2, they are in the lumbosacral ganglion. Okay, so for HSV1, it's in the trigeminal ganglion. For HSV2, they are in the lumbosacral ganglion. So at the times of stress or even spontaneously, so what are the triggers for reactivation? It can be spontaneous, or it can be, there can be fever, or it can be stress, or at the times of immunosuppression, or sometimes due to UV rays. Therefore, reactivation. So this is the general course of the disease. And what is the incubation period for herpes simplex virus? The incubation period is 3 to 7 days. So now we'll talk about orofacial herpes. So first is there will be patient has got the infection, that is by transmission. Patient has got the virus, and after an incubation period of 3 to 7 days, they cause primary infection. And primary infection can be symptomatic or asymptomatic, and it's mostly asymptomatic. Okay, they can be symptomatic or asymptomatic, and only 10% of the patients are symptomatic, and more than 90% of the patients are asymptomatic. So what do these symptomatic patients get? So they have a prodromal symptoms initially, and these prodromal symptoms can be generalized and localized. Generalized symptoms include fever, headache, myalgia, and arthralgia. The localized prodromal symptoms include burning sensation or tingling sensation, numbness, or some uncomfort. These are the localized prodromal symptoms of human simplex virus. And followed by that, there would be eruption. So there would be vesicles, grouped vesicles on erythematous base. So after this, they rupture, they form erosions, and they heal. Sometimes there may be scarring. Okay, this is about the primary infection. So patients, only 10% of the patients are symptomatic. They have prodromal symptoms, and followed by that, the patient has eruptions. The eruption is grouped vesicles on erythematous base, and followed by that, there is rupture of the vesicles. They heal with sometimes with scars. Then they go latency in sensory ganglia, and at the times of stress, they reactivate. Okay, so at the times of stress, the reactivation occurs. So in this also, there might be the patients might get prodromal symptoms, but the prodromal symptoms are less marked. And followed by that, there would be eruptions, skin eruption, that is group vesicles on erythematous base. But here, compared to the primary infection, there will be less vesicles and they're more grouped. There will be less vesicles, but more grouped. Okay, and they rupture to form erosion and they heal. Okay, and the patient will have frequent recurrences, and the recurrences are more common with genital herpes than orofacial herpes. So this is about the human herpes simplex virus 1, that is orofacial herpes. And in primary infection in children, they cause herpetic gingivostomatitis, whereas in adults they form pharyngitis. Okay. So the site of primary eruption in children is gingiva and in the oral cavity, whereas in adults it's mostly in the pharynx and also in the oral cavity. Whereas in reactivation, reinfection, recurrences, the sites will be in the face, mostly in the lips or in the perioral area, the perinasal area, and neck. Okay, these are the sites of reactivation. So in genital herpes, the sites is caused by herpes simplex virus 2, and site of latency is in the lumbosacral ganglion. As I told earlier, when there is erosion, when there is rupture of the vesicles in superficial herpes or genital herpes, they have polycyclic margins. You can see the polycyclic margins. Okay, this is more suggestive of the herpes infection. And then the sites in male and females could be the glands of penis or shaft of penis. And in patients who are homosexuals or like who had contact with other males, they can get infections around the rectal area, the perianal area. In females, mostly they occur in the vulva. It's called vulvitis, vulvitis, vaginitis, cervicitis, and cervicitis is the more common. Okay, so this is about genital herpes. So, what are the complications of human simplex virus? Human simplex virus can lead to secondary bacterial infection, and they can lead to herpes associated erythema multiforme. Herpes associated erythema multiforme. So, erythema multiforme is an hypersensitivity reaction. It can occur because of the infection or sometimes rarely because of the drugs. And the infections more commonly associated with erythema multiforme are the herpes simplex virus and mycoplasma pneumoniae. And EM secondary to herpes simplex is very more common. Okay, and the other complications can be eczema herpeticum, that is based on the superimposed and the pre-existing dermatosis, there is superimposed herpes infections, that is eczema herpeticum. And there could be dissemination to internal organs such as CNS, lungs, liver. There might be corneal ulcers because of the transmission to eye, causing keratitis. So it could be because of HSV keratitis. And sixth, it could be get transmitted to the neonates during vertical transmission. So it's called neonatal herpes. So these are the complications associated with herpes simplex virus that could lead to secondary bacterial infection or erythema multiforme or eczema herpeticum, dissemination to internal organs or to eye, and that can be transmitted to the neonates during labor. Okay, so we talked about eczema herpeticum. So it is also called Kaposi varicella eruption. Okay, it's called Kaposi vericilliform eruptions. So it is herpes infection, herpes simplex infection on pre-existing dermatosis. Herpes simplex infection on pre-existing dermatosis. So what are the predisposing conditions? It could be dermatitis, like atopic dermatitis or contact dermatitis, or it could be bullous disorders like pemphigus or pemphigoid group of disorders, or they can be on the pre-existing dermatosis like erythroderma. Okay, so these are the pre-existing dermatosis, and superinfection of the herpes simplex virus, it's called eczema herpeticum. So what will be the manifestations? There will be grouped vesicles on currently inflamed or previously healed lesions, previously healed pre-existing dermatosis. Okay, so after infection, they form new patches, and they become generalized, and they heal with scarring. Okay, so this baby had atopic dermatitis, and on top of that, if there was herpes simplex virus infection, and you can see multiple polycyclic erosions and on an erythematous base, the perioral area. Okay, this there was HSV1 infection over the pre-existing atopic dermatitis. So complications, they can lead to secondary bacterial infection, and eczema herpeticum increases chances of transmission or dissemination to internal organs, CNS, eyes, lungs, and liver. Okay, you treat it by antiviral, that is acyclovir. So this is about eczema herpeticum, otherwise called Kaposi vericilliform eruption. Next, we'll talk about herpetic Whitlow. Herpetic Whitlow is a digital infection of herpes virus. Digital means the fingers. Infection of the fingers with herpes virus. Herpes simplex. So it could be because of HSV1 or it could be because of HSV2. So how do they get transmitted to fingers? Usually it occurs over the orofacial area and over the genital area. So how does it transmit to the fingers? So it gets transmitted through contact. So who are more prone for contact? So dentists and medical personnel are more prone for contact with the infected fluid of the herpes vesicles, or it could be children with orofacial herpes. And HSV2 cause genital herpes, so there is genital contact, then it could lead to herpetic whitlow secondary to HSV2. Okay, and next is herpes gladiatorum, and this is nothing but herpes occurring in the wrestlers. Wrestlers. So it occurs mostly over the chin, neck, and upper chest, which are the sites of prone more for trauma during wrestling. Okay, so this is about herpes simplex virus clinical features. So how do you confirm whether it's herpes simplex infections or not? So bedside test is Zank smear. So when you do Zank smear, that is when you de-roof the blister and take the blister fluid, and when you take it and smear it on the glass slide and stain it with Zinsser stain, after 15 minutes when you view it under microscope, you would see multinucleated giant cells. Okay, so you can see the multinucleated giant cells. So this is a keratinocyte, and you can see multiple nucleus grouping together. Okay, so there is molding of the nuclei. So this is a bedside test, but it is less sensitive. So what are the other ways of confirming the HSV infection? It's by doing serology. HSV, IgG, and IgM. And these antibodies differ for HSV1 and HSV2, and these HSV1 and 2 differ by the glycoprotein. So they have a G1 glycoprotein is seen in HSV1, G2 glycoprotein is seen in HSV2, So if the antibodies are produced against the G1, it's more suggestive of HSV1 infection, and if it's produced against the G2 protein, then more suggestive of HSV2. Okay, and the other ways of confirming the diagnosis by doing culture and PCR. Okay, PCR is more sensitive. And how do you treat these patients with herpes simplex virus infections? You treated them by giving acyclovir or antivirals. Antivirals. So the dosage regimen differs for the primary infection and for the reactivation. Okay, for primary infection, the dose of acyclovir is tablet acyclovir. It's 400 milligram 3 times daily. You can give tablet val acyclovir, which is 1 gram 2 times daily, and you have to treat it for 7 to 10 days. Okay, and for reactivation or recurrences, there are two types of therapy. One is episodic therapy and other is suppressive therapy. Okay, one is episodic. That is, whenever there is a recurrence, when the patient experiences prodromal symptoms, the patient can take the tablets. And when there are at least 6 recurrences over a year, that is, the patient is getting more frequently reactivation of the virus. So we have to give suppressive dose daily over a period of 1 year. Okay. So in episodic therapy, you give tablet acyclovir 400 milligram 3 times daily for 5 days. Okay, you can give valacyclovir. You just give 1 gram, 1 tablet daily for 5 days. And it's with suppressive dose, you can give tablet acyclovir 400 milligram twice daily. It's not 3 times daily. And in this, it can be 1 gram daily or 500 milligram daily, 1 tablet. This has to be given in patients who are having recurrent infections. That is at least 6 recurrences over a period of 1 year. So you try to give the suppressive dose to keep it under suppression, and you try to taper it and stop it. Okay, this is about the management. And if there's secondary bacterial infection, you can give topical antibiotics. So this is about herpes simplex virus 1 and 2.